Recorded on location at Aspen Ideas Health in Aspen, Colorado.
Margaret, I'm not sure the general public knows that Medicare and Medicaid account for roughly $2 trillion in federal spending each year, and our guest is charged with ensuring patients and taxpayers are getting their money's worth. And she's using new technology to help in her effort.
We want to go find $100 billion in fraud across the programs that we oversee and pay for. We think that is achievable. That's by the end of this administration. And again, the team is building incredible tools to be able to go and do that.
Stephanie Carlton is the Deputy Administrator of the Centers for Medicare and Medicaid Services, and we are so delighted that she is joining us here today at Aspen Ideas Health.
And it comes back to Secretary Kennedy's vision on hey, what we're doing now, the incumbents by themselves, it's not working on the outcomes that we deserve or the affordability that we need.
This is Conversations on Healthcare.
Well, Stephanie Carlton, welcome to Conversations on Healthcare. Welcome back. We enjoyed our conversation last year with you. And there's some news about you. You continue to be Deputy Administrator, but you've actually been given an incredibly new role in terms of artificial intelligence and really quality indicators. Tell us more about the new assignment.
Yeah, well, it is a huge party for Dr. Oz and for his boss, Secretary Kennedy, and for his boss, President Trump, to think about how do we use technology to help Americans get healthier and to drive down the cost of healthcare. And I think we are at just this incredible inflection moment in our history about how technology can help Americans do that. And so my role is thinking about how do we make sure clinical AI realizes its full potential to do that? How do we make sure we govern it responsibly? What's the right role for the government and regulation in it? Yeah. How do we pay for it in a way that drives down healthcare costs? It's always the joke in healthcare that new technology usually drives down costs in most industries, but in healthcare it drives costs up. Right. We don't think that should be the case. It should drive down costs. We care so much about affordability, and here's this powerful tool to realize that and really drive a different way of economics in healthcare. And so that is what I'm tasked with doing. It is not just CMS that has a role in that. We're working very closely with partners across the administration on this. Obviously, the FDA plays a huge role in thinking about how to regulate AI as a device and where they fall in that. We're working with our counterparts at HHS. Arta Kara is a good friend who's just recently come back to government, incredible technology background. So working across the whole administration, we also want to align with folks who have really started the conversation on AI across the administration. We had David Sachs come in as sort of the AI czar and really set out a framework and a charted a path forward on AI across all industries. And now our job is double clicking into what does that mean very specifically in healthcare. So that's the new job.
That's exciting. That's two jobs.
2 jobs, yes, it is.
And to keep you awake at night and put some details on it, that means training about 6,000 employees. But I was struck by a comment I read that it's for CMS to be an AI first agency. Does that mean first among its peers, or is this looking at a different way of really approaching the obviously tremendous amount of information that's coming in every day, the work that has to be done for AI to be the first approach to addressing issues? Tell us a little bit about that.
Yeah, such a great question. So stepping back a little bit, there's a bunch of us that came from business backgrounds and then came into government. So we went through a pretty rigorous strategic planning process at CMS. We did it last year. We just finished it again this year. And so we set out, how do we want to leave the agency and American healthcare different than we found it?
Great question.
And as part of that, we did a set of OKRs, objectives, and key results. It's a framework that's used a lot in the startup community, which we liked because we're moving fast. We only have 4 years under this administration to leave our mark. And so we want to be very deliberate about it. And so there are 4 different pillars to that. I should start. The mission for us is unlocking every American's full potential by making it easier to be healthy. And then there's 4 pillars underneath that. The first one is what you mentioned. Becoming really the leading payer in the country. That's a bold goal for a government payer. But we really wanted to set that aspiration, and our team loves it. Part of doing that is we wanted to be an AI first organization. And so there are things that training our workforce, all 6,000 employees, on how to use those tools that should be an everyday part of their workflows. It's good for their personal lives because they get hours back in their day by using AI. That's huge. We can deliver better consistency and results in what we do, things that we might not have caught by normal manual procedures of doing things. But almost more importantly, it teaches us a different way to think. It's like, how could we use AI to solve this problem? We do it in our workflows, and then we think about for the patients that we serve. How can we use AI to make their lives better, to improve their health outcomes, to drive affordability in their healthcare? So training our workforce then really flows over into how do we make things better for Americans? And that's really what we're about. We've got a whole team. Actually, I had drinks the other night with a new friend from Treasury who's their chief AI officer. She's a former BCG partner, so we kind of hit it off as former management consultants. But you're seeing this real intentional focus across the administration on training our workforces to use AI.
Well, that last piece, how by to actually make people healthier and your Medicaid beneficiaries, people will be watching that intently.
Well, the aspirations are bold and the challenges are great, right? And I think as I look at the Pew Research Center survey, they found that only 38% believe AI use in healthcare will lead to better outcomes. Interestingly, we wear another hat. We run a large primary care system for people who live near or at poverty. And we did a study which shocked us. We have about 150,000 patients, and 75% of them said they were not comfortable with AI in the healthcare environment. And 85% said they didn't want doctor's notes to be used, transcribed in the room. That was pretty shocking for us who are embracing
gung-ho,
are embracing AI. What's your sense about this challenge that the American public has in terms of understanding the safety and security around AI, or that people will be addressing that, or just dealing with change?
Such a great question, and it's a really important one, and that's one of the reasons Dr. Oz asked me to take this on and really focus on it, because we believe in the potential. It's incredible. We also know we have a responsibility to get it right and be responsible about the way that we think about paying for it and regulating it. It's interesting as you dig into some of the numbers, as people get more experience with it, some of the comfort level goes up. We've kind of dug into that data. So that's an important thing. The other thing is, there's a lot of the entrepreneurs that have talked about this. There's a humility that's important as we're thinking about AI and what are the tools, how can it be useful, but then how do we still remain the human element of healthcare and ensure we're getting those safety questions right. And that's really part of my mission. I think there's things that you can do that a lot of the entrepreneurs are thinking about too. And like, when do you escalate to a human, right? How do you make sure some of the foundational models are really trained and very specialized when it comes to healthcare, and how are they getting the best evidence-based protocols incorporated into their models? And a lot of the ones we've met with are very focused on this. There's another piece we think is really important, which is connecting the potential of these models to complete medical records. And we're big believers in that patients should have access to their medical record from every doctor or hospital they've been to. And when a patient has that power and control, they can choose to share it with AI in a safe, confidential way. And then that actually helps the AI give much better answers as patients are just trying to learn more about their health to make the right decisions for them. So I'd say those are two important components. The last one is really their escalation mechanisms that can be built into these models. They are built into a lot of these models today that say, well, you really need a human model, or maybe we need to build in another specialty track to deal with a super specialized medical question. And those are the kinds of things that are top of mind for us, that are top of mind with many of the innovators that we're talking to about this.
And yet the last image that people had was that first introduction to AI where it hallucinated. And people are still thinking about hallucination versus about the people are addressing that issue.
Yeah. And I think that's the thing where we know there's risks,
Yeah.
right? The important thing is let's identify those risks and then have a plan to manage those risks, because there's so much potential for public good if we get it right. And so the important thing is don't just say we can't do it.
Right.
It's more, how do we do it in a way that's safe and responsible that manages those kinds of risks?
Yeah.
Well, on this issue, I would say you're in the fray with everybody in healthcare
Yes.
in the country, coming at it different size, different angle, but these are all very timely issues for us to think about. And one thing that you have to think about at a much larger scale than people in the field perhaps is the issue of fraud and Medicare fraud, which obviously accounts for a lot of losses. And I understand you even have a fraud war room, expression I hadn't heard applied to fraud earlier, but that you're thinking that AI might really be a servant to you in this, in terms of being able to maybe increase results and decrease some of the personnel burden. Tell us about that.
Yeah. So as we think about fraud, I mean, you mentioned at the beginning, we have a $2 trillion budget across Medicare, Medicaid, the exchanges. There's a lot of opportunity for fraud. And what we found, Medicare, we were doing okay. There's some improvements we needed to make and edits. On the Medicaid side, we had 6 people managing oversight on Medicaid fraud. Think about that. $900 billion program in Medicaid. We had 6 people at CMS working on it.
Wow.
We had a lot of work to do. Obviously, Medicaid is a partnership between us at the federal level and the states. And we found is the states need a lot of help. And there's some of these things, if we build better data systems, better partnership with the states, and use AI to track what are the patterns across these massive sets of claims and billing, that we can go identify, hey, this service really spiked up. Maybe there's some kind of a problem that's not explained by normal provision of care. Or this kind of provider really spiked up. Maybe we don't have the proper controls and safety considerations in place. And so those are the kinds of things that we're implementing now when it comes to fraud. Again, the big focus has been building out our capability and focus on Medicaid. My colleague Kim Brandt, who is our COO, she actually was one of the youngest career senior executive service members at CMS almost 20 years ago. And she led the fraud fighting function at CMS. And now she's back almost 20 years later, and she's really bringing in things that she's learned from the private sector, that she's learned across her career, to bring it back up to speed from when she was there 20 years ago.
Wow. Have you been able to set a target of what you might be able to accomplish, or are you just going to give it your best shot and see where you land?
We have, Dr. Oz has been, and Kim have both talked about, we want to go find $100 billion in fraud across the programs that we oversee and pay for. We think that is achievable. That's by the end of this administration. And again, the team is building incredible tools to be able to go and do that. And it is something, and I get to spend a lot of time with Dr. Oz and Kim. It comes up every single day. They are focused on this relentlessly.
And yet the public, the KFF Health News poll found that 58% disapprove of the way the administration is handling fraud and abuse in government. Is that a number that may never change? When people hear the number 2 trillion, they always think you could probably do more with less. Is that endemic to the American sort of psyche, that government, there's bound to be things that aren't functioning the best way?
I think when you show the data to the American people and show them what's going on with their tax dollars, they get pretty frustrated about the kinds of things that have just slid, and the government that is supposed to be stewarding their resources has not focused on. Conversations I've had, polling I've seen, people are outraged that this kind of thing is happening, where we're cracking down on, foreign syndicates that are robbing, our taxpayer dollars. People are really frustrated. Kim and Dr. Oz, the fraud task force that's chaired by the vice president, are very focused on getting it right. Obviously, you want to be careful and precise about it, and you want to make sure we're not getting the folks who are doing the right thing, but there is so much opportunity. I think you've seen some of the data on some of the autism therapy providers, where you've got billing that's getting close to $1 million over the course of years. Like, something feels off about this, right? And you dig into the data and you're like, oh, this is not what we intended. We care a whole lot about autistic kids and we want them to get the care that we need, but there are folks who are bilking the system, and that's not supposed to happen. So every time I see folks that see that data, those kinds of real stories that we're uncovering, more and more of every day, they're frustrated and they want us to do more.
Well, I'm only going to ask one more question about this issue of fraud and only tie it to the issue that probably trumps that in size is the question of insolvency, a future potential problem of insolvency. Where do you stand at this point in terms of looking at that as a risk? And do you feel you have sufficient strategies going to mitigate against it?
So talking about Medicare insolvency.
Medicare insolvency, sorry, yes.
Yeah. Obviously, we work closely with our chief actuary who does the analysis that informs the trust fund's status. Dr. Oz is the secretary of the trustees for both the Medicare trust fund, and then we work closely with the Social Security folks on that, and that's chaired by multiple cabinet secretaries. And they spend a lot of time on this and take it very seriously. They understand the importance of those programs to Americans. I remember the president was the Republican in the field of many candidates in 2016 that was talking about how important it is to protect Medicare and Medicaid and Social Security. So that starts at the top for us and being wise stewards of it. So the program not only works for those who are on it today, but it is around and working well for those that need it in the future. So that starts at the top. I think as we think about it, there are tough decisions we are having to make as a team as we steward the Medicare program. Chris Klump is my colleague that runs Medicare for us. He comes from a private sector background that is really conscious of, as a business leader, you've got to make the hard decisions. And so they have really done that on multiple fronts. We came in January 2025, and we saw the spike in the data on skin substitutes in Medicare, where it was a few $1 billion that we were paying for it, and then it was on a trajectory to be almost $20 billion over the course of a few years. It's like something's off on this, and we found there was a way for bad actors to game the system in how they were paid. And Chris took some real hits from special interests in Washington and prevailed and did the right thing. But those are some of the hard choices that we've had to make as stewards of the Medicare program.
Some targeted and some broad.
Some targeted, some broad. And I think some of the broad ones, good segue, are to look at what are some of those structural drivers of healthcare costs.
Right.
And I think about that in a couple ways. There's a demand side of that. There's a supply side of that. On the demand side, this is what Secretary Kennedy's Make America Healthy Again agenda is all about. We are a sick country when you compare chronic disease rates to our peer countries, other westernized countries. Our obesity rates closer to 40%, about half that in Europe, half that in many Asian countries, a tenth of that in many Asian countries. And that shouldn't be the case, and it's a huge driver of costs. And so much of what Secretary Kennedy has been focused on are, let's get that right. How do we equip Americans to take better care of their own health and make better decisions? How do we make it easier for them to be healthy? And if we get that right, it is a huge driver of affordability and driving costs down for the whole system. So I'd say that's on the demand side that our team has done a lot of work on, again, really led by Secretary Kennedy's vision there. And then on the supply side, it is our job to think about how are we stimulating competition? How are we challenging incumbents in healthcare, hospitals, clinicians, pharmaceutical companies to drive down and make their services much more affordable? A good example there is the challenge the president gave us over a year ago, which was to take on prescription drug pricing. He didn't want to pay more than other westernized countries did, called most favored nation pricing, and folks said it was impossible. A year later, we have struck deals with all of the 17 major drug manufacturers in this country to bring down those prescription drug costs. And that's a good example of, on the supply side, how do we bring down the cost?
On a specific list of high volume, high utilization meds.
Stephanie, I want to pull back a conversation we had a year ago about the work requirements that were going to be put in place for Medicaid and SNAP programs. And you were talking about trying to make a system that was efficient, effective, and elegant in terms of reporting. I think there's a lot of angst out in the country about how this is. I think the requirement is that 20 hours of either work or other related activities, volunteer work, could be accounted. But how is that globally being managed right now? And are we close to something that's going to work efficiently for all of the 50 states?
Yeah, absolutely. it's obviously consumed a lot of time for states. They've been working hard the last year. We've been working hard the last year. And they're on track to a go live of January 2027. There's some states like Nebraska said, "Hey, we want to get out there, well over 6 months before the deadline." So they kind of led the charge for us. What has been fun to watch, and I got to work with Dr. Oz to build the team at CMS. And set the strategy. We tried to hire talent that was different and shocked people, actually. So Dan Brillman is the guy that we hired to run Medicaid for us. Incredible leader. He also comes from a business background that is using technology to help make people's lives better and navigate bureaucracy at the state level and figure out what benefits am I eligible for, how do I cut through the red tape and get what I actually need, and then ultimately, how do I help myself succeed, and how do I have the tools to make more of myself and accomplish my personal mission? So we brought him in, and he has had just incredible background of thinking about how do we use technology as we're implementing work requirements. He's done things like negotiate with some of the consultants that work with states that are helping develop this, and got about $600 million in savings just because we're building kind of the same IP across states and asking them to give states basically the discounts so that they're not having to pay for the same IP over and over again. And then work with them and start to standardize some of the things we're doing on IT so it makes it easier to implement.
So
those
not
things.
a 50-state solution, one technology solution, or
we talk about it as, when it comes to IT and Medicaid, there's probably 70 to 80% of the functions that could be standardized across states. There's still some customization. We believe in states running their programs still, but there's a lot of the standardization that can really reduce inefficiency, reduce costs, and make it easier for states to meet their obligations in the program. And that's been a huge part of Dan's mission.
Maybe I can get you to help us pull it down to the ground for our listeners on the IT element. And I will acknowledge that some of this I'm only learning pretty recently myself. But as I understand it, when you think this enormous shift in the state, part of what the IT systems will help with is letting states identify, just through the claims they already have in their systems, who are the medically fragile people who would be exempted from the work requirement. And what I've heard administrators in my own state talk about is that they probably, up to 60% of the people who should be designated, about 60% of the people will be automatically designated by their systems as medically fragile, leaving still a big challenge for others to work with people if they do qualify for an exemption, to be able to have it. Is that another way of talking about this use of IT, that we will use data that we already have to protect people who should stay exempt from the requirements, and let the people in the communities who support people actually work with the individuals who still are in a gray zone? And will there be a period of time, maybe allowance for people to work through that issue of the exemption? Long question, but it's on the minds, I think, again, at the grassroots level.
Yeah, it is on the mind of a lot of folks at the grassroots level. And our job has been to implement the intent of the law passed by Congress. That is, how do we put encouragements, incentives in place for Americans on Medicaid who can work to work? It's obviously broader than that. It could be work, it could be volunteer service, it could be school to go get a better job down the road. So we're very flexible about the kinds of things you do. The principle is, how do we make it easier for Americans to engage in their communities? To make it easier for, again, people who are able to do it. That's the spirit of it. And then our job has been to provide clear guidance to the states. And as you said, we're committed to a data-based approach to it so that we're objective, it's not subjective, so people know what they can do, and then also provide appropriate protections for people who really can't work. And I think the spirit of it was to balance those things and be objective about it.
Stephanie, I want to go back to what you said, the bill that Congress passed, HR 1, the one big, beautiful bill. And one element of it, as I'm sort of going to do the good news, bad news, is rural health transformation. $50 billion new dollars for rural health transformation out to all 50 states. And yet, when you look at the data around the losses that rural hospitals are facing right now, the closures that are happening. How are you thinking through this? How's the program going? And how is it addressing the sort of larger reductions that happened in rural health?
Yeah, so I would back up. I mean, I worked in the Senate for about 10 years, more than 10 years ago. This has been a while, and I've been studying rural access for a long time.
Yeah.
And this is not a new problem, right? The changes in how we finance Medicaid have not really taken effect yet. And so the data that you're seeing now on challenges rural hospitals are facing is not a new problem. That is a decades-old problem. And so as we looked at that, we really want to ultimately get to better outcomes in rural areas. Hospitals and clinicians in rural areas play a really important role in that. But the end goal is outcomes for the individuals living in rural areas. So as we thought about that, we wanted to look at why are many rural hospitals closing? And we didn't want to just say, let's just spend more money on a system that has been challenged for years. We want to say, what are the core problems? And then how do we start to fix those? And that's really what the Rural Health Transformation Program was about. We wanted to equip rural communities with the tools to make big bets that are game-changing for access. Part of that is training rural workforces, right? How do you get doctors or nurses to invest their careers in those kinds of communities where the need is so great? How do you use technology to help those clinicians really succeed and really upskill what they're able to provide to Americans in their own communities? I think we're seeing a lot of innovation there. Another thing, this was a priority of Dr. Oz's, even before he started, about thinking, you've got some of these bigger health systems in cities. How do we actually help them support some of the hospitals in rural communities that are really struggling with staff, with back office functions, and then how do we help them thrive? And so we're seeing that play out as part of this.
How is the program rolling out, though? I think CMS has said we're only going to approve 1 year at a time. And then the question of themes, they're really being set by the state. CMS is not saying, by the way, we're all going to get on board with this type of innovation, right? So, but first of all, is the program sort of going to launch on time and successfully?
It is launching. Yeah, absolutely. We made our awards January, more than 6 months ago now. States are implementing and going through procurement cycles and executing on the plans that we had to approve. So it is very much on track. The reason it's only approved a year at a time is because we were given an obligation by Congress to oversee those dollars and be stewards of them and make sure the dollars were really used as intended. And so we partner very closely with the states as they're implementing these things and make sure things are going to plan. It wasn't just write a $50 billion check and then check out, right? It is write a $50 billion investment and then partner with the states to make sure it reaches its full potential.
Well, it is one of the tremendously large, fast-moving trains that's out there, and I'm sure we'll be reading reports, hopefully reading reports regularly and often of how it's going. On a smaller scale, but something that created buzz in the provider community was a program that's been released, no decisions made on awardees yet. I think it's under the category of MAHA Elevate, where you went out to both the academic people, but the provider community and said, do your studies and show us what do we not cover today that might make a real difference in people's health and health outcomes and save money that might potentially, therefore, down the road, lead to being covered. What are you seeing with that? Yeah, any early indications about excitement in the field about that? Do you think there's potential for that kind of direct feedback about what might Medicare not just think about what shouldn't be covered, but what should be covered, as you said earlier, around some of those medications?
Yeah, that's a great way to frame it. And there are certain standards and evidence thresholds that we have to abide by under
very
law.
rigorous.
Yep.
Yeah.
But at the same time, we're very excited about some of these non-traditional pathways and therapies that have a real impact on people's health and wellness. So MAHA Elevate was intended to give people the resources to go and test those things and start to generate the evidence base that then allows us to consider coverage down the road if we can prove that the data supports those kinds of outcomes. And so we've been very encouraged both the excitement about this and the kinds of proposals that we're getting as part of that. I'm not allowed to speak about it quite
Sure,
yet.
of course, it's early.
We're very encouraged and excited about it. And it, comes back to Secretary Kennedy's vision on like, hey, what we're doing now, the incumbents by themselves, it's not working on the outcomes that we deserve or the affordability that we need. And this is an intent to say, hey, let's think bigger and bolder about how do we make America
and a great message to put out there to the country.
Stephanie Carlton, thank you so much. Congratulations on the new job, and thank you for joining us again. We look forward to continuing to get updates from you and continued success.
Thank you both. Great to be with you.
Thank you. This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.